Our first keynote speaker is Dr. Siegel. Dr. Siegel is a physician scientist specializing in psychosis. He received his BA in neuroscience at Colgate University and his MD, PhD in neurobiology at Mount Sinai School of Medicine 30 years before I was born there. He completed residency in psychiatry and fellowship in neuropsychiatry at the University of Pennsylvania. And Dr. Siegel spent 20 years at Penn, where he had roles in research, teaching, and clinical care. His laboratory studied electrophysiology. Oh, they don't give me the easy words, okay? Electrophysiology and molecular mechanisms related to severe psychiatric illness, and invented and licensed drug delivery technologies for the treatment of schizophrenia. Dr. Siegel was appointed professor and chair of the Department of Psychiatry and Behavioral Sciences at Keck School of Medicine, USC, in 2016. In 2021, he became Keck Medicine's inaugural Chief Mental Health and Wellness Officer. And in 2025, he was appointed Vice President for Behavioral Health at USC. So let us welcome my friend, Dr. Siegel, who will be discussing USC's Student Mental Health Screening Program. Steve?
Good morning, everyone. So before starting the presentation, I actually have the privilege of presenting some awards to very special people who've made this event possible. And so I'm going to read briefly about each person, and Marie will help present their plaques. First, the first award recipient is Dr. Clifford Feldman. Dr. Feldman is a board-certified, psychiatrist and serves as the medical director of the geropsychiatry unit here at USC Verdugo Hills Hospital. He has been actively involved in the Verdugo Hills Hospital Suicide Awareness and Prevention Conference for the past 10 years, serving as the moderator for the last 8. Cliff, please come up for your staff.
I'm unprepared. I'm speechless. How can I go on? Thank you so much.
Thank you. Next, we would like to thank and honor Robert Storr. Robert is a licensed marriage and family therapist and the executive director of USC Vets Patriotic Hall in Los Angeles. He has been actively involved in the VHH Suicide Awareness and Prevention Conference for the past 10 years, serving as the conference director for the last 7. Next, we'd like to thank Purnima Panchal. Purnima serves as the Community Education Manager for the Senior Behavioral Health Program at USC Verdugo Hills Hospital. She is also a co-founder of the VHH Suicide Awareness and Prevention Conference. Next, we would like to recognize and thank Deborah Wyrick. Deborah is the former Director of Community and Donor Relations at USC Verdugo Hills Hospital. She has been actively involved in the VHH Suicide Awareness and Prevention Conference for the past 7 years and has served as a dedicated volunteer on the planning committee for the last 3. So with that, it's really a pleasure to be here and an honor to be able to describe what I think is a really special program developed at the University of Southern California with the explicit goal of reducing morbidity and mortality from mental illness and attenuating suicide. This program is called the USC My Mental Health Program, and it serves all USC students. It came from a time in the Department of Psychiatry when we came out of the pandemic as an organization, realized that event, the pandemic, had been a huge galvanizing force for us. It had taken an entire department of about 400 people at that time, spread throughout Los Angeles, from the Martin Luther King campus, where we have our inpatient unit at the time, to LA County Hospital, Student Health, Verdugo Hills, all of the hospitals in our system, where we had people who typically worked independently, came together during the pandemic to support USC. And as we came out of that, we decided we needed a purpose to be our galvanizing force. we call our rally cry. And we decided to make USC simply the finest student mental health program in the world. And it sounds like an auspicious goal, but I believe we achieved it. And the flagship, the crowning jewel of that program is this My Mental Health that I'll describe today. And that decision to focus on becoming the nation's premier student mental health service did not happen in a vacuum. It happened in recognition of the kinds of data that you see here, where we've seen an enormous increase in both the acuity and frequency of serious mental illness among children and adolescents and college-age youth. Most notably, or notably within that, we see that there's been nearly a 60% increase in deaths by suicide among adolescents and young adults. And this stark realization, again, fueled our desire to reach people early in their progression and attenuate the suffering and really try to stop people from reaching the acute stages. When we set out on this program, we set three major goals. One was to find a mechanism for proactive screening out in the community where we could reach people and have a rapid, accurate way of creating diagnosis and severity scores. The second was to make sure we had appropriate systems to treat people if we found them in the community, building out the treatment pathways. And the third was finding ways to destigmatize participation so that people would come into this system eagerly and willingly and want to be cared for. In order to do that, our research group, as I mentioned, this was the entire department, whether they were student-facing or not, came together, and our large research group took a year to determine what's the most appropriate, most accurate, most evidence-based, but also most enactable way to reach out and find people in the community and bring them into our system. And they arrived on using a technology that we purchased from a company called Computerized Adaptive Testing. That company grew out of academia, and they've taken hundreds and hundreds of questions, maybe thousands, from validated surveys and found a way to use adaptive testing, meaning that we ask a question, and based on your answer, the algorithm then decides what the next appropriate question is. And that would take, for example, a 50-question depression screener that might take 30 minutes to do, and it will very rapidly have a very high estimate of that outcome in 2 or 3 questions. So it might look like, are you feeling sad? Yes. Do you have sleep disturbances? Yes. Have you experienced periods of crying? Yes. Now it's made a diagnosis of major depression with a severity score, and it'll move on to anxiety, PTSD, substance abuse, psychosis, et cetera. And in doing that, this technology takes what would normally be 2 to 2.5 hours of testing with a trained neuropsychologist and can replicate that outcome in about 9 minutes. And this is important because if you want to screen a population, 2 hours one-on-one with a trained healthcare professional is just not realistic. But 9 minutes on your phone, that's very real. And if you can do that with the same degree of evidence-based accuracy, you can really make a difference. So, as I mentioned, this allows us to now take the technology we bought and build a workflow, a pathway that brings this in a very real way to our community. So the way it works is we'll send out a letter to each student. So it's individualized. They get a personalized communication signed by the president of USC. So we got buy-in at the highest levels. And it will say, "Dear John, we want you to participate in your own mental health and wellness. Please click on the link below that will bring you into our survey and into our healthcare system and provide the services you need." The person then clicks on that link. It will bring them automatically into the survey. As I said, 9 or 10 minutes for them to do that. And at the moment they complete it, so literally within a second, they hit done. The programs calculate the result. Again, our clinical teams now, and that's why I have this up here. So we have a research team, a clinical team, an operations team, crisis team. And to put this in perspective, this group met for an hour and a half every Friday night for about a year and a half before we were able to launch, with no funding, just people feeling like this was the right thing to do to build this system that I'm describing. And so as soon as you hit done, what we do is we take that output from the computerized adaptive testing, and that's a 10-page report of data. And then we turn that into, again, using evidence-based algorithms, diagnoses and 5 severity score categories, which I'll go into. In that moment, it communicates back to the participant, the student, what their recommended treatment is. So as you'll see, whether you had no symptoms, mild, moderate, severe, or acute, you're going to get a pretty different letter and different outcomes, but it's automatically now linked you to the health system, and the health system is responding. And as I mentioned, we're going to have essentially these 5 categories: none, mild, moderate, severe, and acute. And I mention that because the quotes that I'm showing, or I mentioned it again here, the quotes I'm showing map on to the sorts of responses we've seen and the way that it's landed on our student population. So before I get to the quotes, you might be thinking, how do you do all of this all at once? And we don't. So the first year we launched it, we did 12,500 students. It was everyone who came to USC for their first year, whether that's a transfer student, a freshman, or a graduate student, but 12,500. The next year, they all got it again. So now we can get serial assessments as well as cross-sectional. And the new group, and so forth and so on. So this year, we're in our 4th cycle, and we will go out to 45 or 50,000 USC students. So essentially, everyone who's been at USC for 4 years, if this is their 4th year, and we've built mechanisms to figure out if there's people in 5th and 6th and now reach out to them. We take that sample, so 50,000 people, and this is going to be important in interpreting the data. And every week for the entire academic year, the computer, our program, will pick a random sample and send out essentially 1/20th of that sample. So 2,500 students get an email each week. This allows us now to throttle how many people are going to come in, right? Because we can't have 50,000 people show up at once. It also allows us to be sampling the state of mental health across the academic year for diagnoses and severity, so we can see how the academic life varies in terms of the impact on students and when students are having more or less acuity. And then there's portals so that anybody can come in at any time on top of that. So for some people, they get the survey, they do the answer, and this first quote, talks about it was just nice to have this. The person says, I have a lot of things inside my mind that are not going away, even if I pray or meditate. So they're acknowledging there's things going on, but this might be a mild, or moderate. The second person acknowledges they're really having a hard time. And the third person speaks to why we're here today. Whoops, go back, sorry. So this is what that cadence has looked like over the last 4 years. We have about a 15% response rate. When we get to Q&A, I'm hoping somebody asks, why is it voluntary? So I'll cue that up. But it's completely voluntary, and we have about a 15% response rate. What we find is over the 3 years, actually about 20%. So about 15% the first year, goes to about 8% the second year, 4%. There's some overlap there, but you get about 20% of the population. And this year we'll get them for the 4th time, and we'll find out, what proportion of a class eventually takes the survey. Within that, importantly, and I'll show you some real data here, 9% of the population are coming into what we call our high and acute categories. And this is what that data has looked like in a very granular way over the last 3 years. We see a full 2/3 of USC students, random sample, so this is again why I emphasize this. These are not people coming into the center. They're not people being identified by someone who's concerned about them. It's just a random sample, self-selected for applying. So we have to know there might be a response bias. But if you look at the no and mild, that's 66% of the population. 2/3 who have either absolutely nothing or just only the mildest of issues. And those people, as you'll see, are going to get a communication that says, for all intents and purposes, you're doing great. We hope that continues. Here's a whole list of resources we hope you will participate in. And if something changes, do this. And that'll include some drop-in groups, some online resources, the ability to come and meet with counselors if they just want to talk. So it's not like nothing, but they're not given an appointment. On the other hand, we see 25% of our population actually meet criteria for a bona fide mental health illness. So this is going to be, moderate depression, but the person's going to class, they're getting out of bed, they're eating, and they are told, you should have an appointment. Call this number, click this link, use this QR code. We will see you within days, 2 or 3 days. And if we don't hear from them, they'll get a reminder. But if they never see us, we just leave that be. The next 6% are responding in ways that suggest or indicate severe mental illness. This is a bipolar disorder patient in the manic phase who's reporting that they're not sleeping, they're not going to class, they're having severe symptoms. A first break psychosis, severe depression where the person's indicated they're not getting out of bed, they're not going to class. But they have to have said no to 3 questions. Do you have a plan, intent, or have you acted to end your life now? Random sample, right? So again, not a hospital, not an ER, you're just like going out to this room and sending a survey that says, by the way, are you thinking of killing yourself right now? Have you taken action, or do you have a plan? And 3% of USC students at any given time who answer the survey answer yes to that. So 6% say no, 3 more percent say yes. So that's our high and acute groups. These will get a very different response. So if you've indicated you have in the middle of a severe episode, but you are safe for now, you will be contacted within 12 hours. So next morning, 7 days a week, one of our counselors, our crisis counselors, will get on the phone. They'll start calling, texting, reaching out. And we say, we'll need to speak with you within 72 hours. And people consented to this when they came in. And if we don't hear from you, we're going to send our mental health team out to your location to find you. 3% that say yes, that wakes somebody up. So midnight on Sunday, that answer, the person hits go. They get their notice that says, be ready for a call. And it'll wake up someone on call on our team. and they will start reaching out right now, texting, calling, trying to get in hold of that person. And that person's message is you have 48 hours to come and speak with us, or we will find you. And we have over, what just happened? Did someone signal that my time is up? So we've had 700 or so students in that so far, and every single one of them has met with one of our counselors within that specified period of time. So moving forward and trying to stay on time, we then match them with therapy, psychiatry services. We can get someone into an IOP. We've hospitalized many of these students right then and there that night, and then we will continue to care for them through the rest of their mental health journey. We have a high-risk team that I have for after the Q&A if people want to learn more about it. And we'll actually follow students regardless of whether they're in our student health practice, our commercial practice, or out in the community. We will actually keep track to make sure that they're still okay. You can see the numbers on hospitalizations here at the bottom. And I would argue these declining numbers over time reflect the impact of reaching people early before they come to us needing to be hospitalized. But if you find people when they are mild and tell them how to get help if they move to moderate, that will attenuate. If you find people when they're moderate and keep them from progressing, you'll have fewer, severe. And if you find people who are, in that high group and reach out to them and bring them in urgently before they get to acute, you will attenuate hospitalizations and obviously much worse consequences. So, whoops, I'm happy to share these slides with people. These are some anecdotes that we've put together with permission that really tell the story of someone who was struggling, wasn't really engaged in care, took the My Mental Health assessment, was reached, came into system, and changed their life trajectory. This is what I mentioned. So you have your groups, and importantly, these are additive. So everyone gets all of those interventions, then plus a clinic visit, plus an outreach, plus an urgent outreach. These are, as I mentioned, we have a whole host of services to make sure that once you reach us, we actually have the bandwidth and the capabilities, the specialty tracks to care for you. And here just gives you a sense of the kind of data that comes in from this that helps us understand the needs of our community so we can design services proactively based on what we're learning about the population we serve. So as an example, if you look at the depression scale, it's saying of the population, we have, it shows here 85% of the population are coming in with really nothing. But on the depression score, 11% moderate and 5% severe depression. And then the algorithms will put together if you have severe depression and moderate anxiety and high impulsivity and moderate drug use, acute, or severe, and then those three questions to move to acute. So our algorithm takes all this data and then puts together a risk profile based on the constellation of outcomes. Again, this isn't so that everyone sort of scrutinizes every detail, just trying to give you a feel for how we think about this. We look at demographics and helps us understand how we need to tailor our survey, who it's reaching and who it's not. As an example, we see that Asian and Asian American students participate in this survey at twice their fractional representation at USC. It's reaching this population. So there's 42% of the respondents are Asian or Asian American, and only 20% of USC students are. On the other hand, if we look at our Black and African American students, what we're seeing is half of the proportional representation. So this tells us we need to work more to make sure that we're reaching all populations with our outreach efforts and our marketing. So, here I just have a couple of anecdotes that, again, really personify for us how this is helping people. Some people just say, I'm grateful that you're doing this, right? This is obviously not someone who had to do something in the moment. Here's someone who, needed the survey and took advantage of it and got into care right away. And then, there's people that, get this survey and it's like kind of a lifeline for them to reach into the care system and get help. So, again, an example of someone who's struggling with suicidal thoughts and they get this survey and it's a way for them to get care right now. So, moving towards the end, as I mentioned, we've built this out over time so we could have the bandwidth to respond. This has been incredibly well received in our philanthropy community. The department's raised $23 million to support this. So this isn't paid for with student health fees. This is all paid for with philanthropic dollars. And we've been really gratified to see that this has received so much support. We also think it's a model for not just USC and other colleges, but and I'd be happy to go into this either if we have time, now or with people individually. This can be adapted for other colleges, for secondary schools, for health systems. We're working with a reservation in Montana to try to do this for a whole rural community in northern Montana. So you can build the system to match the capabilities of the health system and the needs of the community and be that bridge between suffering, out there and the ability to help here. And so with that, I'd like to thank you all for the opportunity to share this today and thank the organizers for this conference. So according to my watch, we have 5 minutes. Is that right?
Right. So thank you so much, Dr. Siegel. We're going to take some questions for you. Okay. So if anyone has any questions, raise your hand and we'll be with you.
Hi, my name is Precious Jones with the Positive Results Center. And I was noticing that you have different demographics for different mental illnesses, and they are effective in decreasing that population's suicide and risk. I was wondering if you have any demographics for burnout or students who may be facing burnout, because especially for grad school students, that is a risk that is necessary to address. And so if you do have questions pertaining to those, how do you cater to those students to ensure that they feel they belong and can keep going in that school?
So I think everyone heard, right? So the question, and thank you for the question. So the question is, this is all about mental illness, right? We're talking about, and I showed the domains, these are things like depression, anxiety, PTSD, psychosis. And the question is, what about people who are just burnt out, demoralized, facing fatigue? So this survey is only going to pick up the domains we asked about. I would imagine that somebody who's feeling, exhausted, mentally exhausted, emotionally exhausted, they're going to come across with these questions in a way, but probably on the milder side. They're going to get those initial resources and the ability to engage there. But this is just one piece of our puzzle. So this tool isn't the burnout survey. It isn't the wellness intervention, but it's part of a much, much larger system. We have 100 faculty members between our student health and commercial practice that are student-facing only. There's also embedded counselors in the different schools and cultural organizations. There's even wellness in some schools, wellness counselors that are outside of student health. And all of that infrastructure is designed to be able to reach people not in a mental illness mode, but in a burnout and demoralization mode, and create programs and interventions that help people just with daily struggles. So we do that. We don't do it with this tool, though. But thank you for bringing that up. Oh, thank you.
Would you be interested to look through a system which comes after this for monitoring and having everything posted to the attention of the specialist?
So I'm not 100% sure I understand. So I'm going to try to rephrase what I think you mean, and then you can tell me if I got it. So are you asking how we then move to the next phase and incorporate this data in care? No.
I know a system which is the next phase. And this system is available to be presented. Will you be interested, or anybody will be interested to see the presentation of that system?
So of course, I would always be interested in learning more, and without the details, I would just say, yes, I'd be happy to learn about that. Eager. We can connect. I'll be here all day. I can connect with absolutely anyone here and arrange for ways to communicate, after the conference or during the conference. So my contact, I can do this easy. It's, let's see if there's a way to go all the way. Well, my name's in the program. Siegel, Siegel, S for Steve. So think of it like plural, Siegels at usc.edu.
First, it's wonderful presentation. I was a USC graduate student, and I worked there also for 18 years as a director at one point. My question is, I wonder about the impact of your program on decreasing substance abuse and dropout rate.
So I think it's hard for, the short answer is it's impossible, hard if not impossible for us to look at how one program in isolation is then having the impact on these meaningful life outcomes like substance use and dropout rates. We do as a university clearly look at those, and we have programs for substance use disorder. So as an example, we're screening for SUD here. People come in, this data makes its way to the clinician as an aside. So we generate a report that is, it's not the 20 pages where they have access to that, but it creates a brief summary report that'll go to the clinician. So for example, a student who does this comes in for care, their clinician and in fact their internist will be able to see what their substance use profile is. And we actually have a substance use disorder track, so to speak, a specialty track, both in our student health practice and our commercial practice, where we'll take, a student can go through that sort of trajectory from the initial intake, stabilization, and then long-term care. So that wouldn't have existed when you were there. That's relatively new. But that's one way we're addressing it. There's also been huge efforts at USC to try to attenuate substance use through outreach programs, for example, in the Greek community where it's been a particularly prevalent issue. Similarly, we work very, very closely with the offices at USC that are aware of and offer help when a student is struggling academically. And so these are not happening in isolation. Academic struggles, behavioral struggles, mental health struggles, we all talk to each other in not just like water cooler talk to each other, in organized forums that make sure that a student who's struggling academically, that's the mental health system is aware and can intervene if the student wants it, and vice versa.
Hi, we
oh.
know one another. I'll just introduce myself to the room. Sam Michelle Kennedy, Los Angeles. I just wanted to thank you for an amazing presentation and for the work that you've done and that your team's done. I was curious if you have or you intend to look at some of the planning this like this saved by hospitalizations, etc. I don't know. There, the purpose of other universities being further incentivized to see that this isn't just the right thing to do to support people who are suffering, but it also makes economic sense. Potentially for insurance companies as well, but more resources and more support for preventative care is such a big issue.
Yeah, so thank you. By the way, when I'm making eye contact with people and they've got their hands up and then they don't get called on, I'm not doing the calling on. So I just don't want people to feel like I'm ignoring them. There's a mic moving around. So to that point, again, like it's very hard to link a tool to a concrete outcome. However, we USC, the Department of Psychiatry and Student Health do work very closely with the insurance products that our students have and have to make the case for not just do what's right, do good. We also have to make the case continuously that this is the right use of resources to achieve the best health outcomes. And that includes creating, as an example, I've mentioned this two practices, student health and a commercial practice. So back in 2019, we realized that one of the biggest challenges at USC was that students would have this brief intervention at student health, maybe 3 to 5 sessions, have triage, diagnosis, and then be referred to the community where it can be very, very difficult to get care. So USC invested in our department and we literally built an entire floor on campus where we have 35 faculty members and we provide a commercial clinic that takes students' insurance that provides care right on campus. Because we tend to see the students who need the highest level of care there, it's an expensive practice. And that has to get underwritten. And every single year, as I think is appropriate, we need to provide the data that says, this is providing a rather expensive, but very high level of care. And the alternative to this is going to be IOPs and PHPs and hospitalizations, which are important, but to the extent that we can offer this very high level of care on campus, we can at least bend the curve and help some students go from inpatient to PHP, some from PHP to IOP, some from IOP to this. We see ourselves as sort of it's like right below IOP. It's for people who need a lot of very high level services, but don't have to be, every day. And, I had as an example, just to that point, I'll try to get through quickly. The thing about if there was time after the Q&A, some of the programs that we have in that clinic, and, this includes, we have every clinician there has mandatory time every week to sit in conference and run through the list of high-risk students. Then those clinicians have a mandatory, they have to sit through case conference on the students who are identified in this week's high-risk conference, and there's about 90 at a time, and none of that's reimbursed. So it's a couple of hours a week of intense clinical activity that there's no way to bill for. And that's just the cost of doing business. And we make the case each year to the university that the only way to provide this level of care is to have those mechanisms. And at this point in time, there's just no way to be reimbursed for that. So we're going to just have to underwrite that as a system. So it's not exactly the question you asked, but I hope it speaks to the motivation, which is we do have to be sensitive to cost
Should we go to it now?
and aware that increased cost must be tethered to better outcomes.
Thank you. We're going to take the last question online. What does the post-mention plan consist of, particularly for those students with high or acuity levels who leave school abruptly or graduate?
So this is, I think, the next frontier, right? So our engagement with students really ends when they leave USC. And it's not abrupt. Right? We tend to know for most students, and I'll get to the leave abruptly, we tend to know for the vast majority of students when they're going to graduate and that they're going to need an aftercare plan, and that we help them, say, well, there's going to be an end to your journey here. So we have like sort of an end process to care with us and a handoff to try to help them find care in whatever community they're going to. But this is a real challenge because, as you can imagine, people are going to different states, people are going to different jobs, they're going to have new insurances. There's really not a way to get them all tucked in with a clinician wherever they're going to be, with whatever their insurance is going to be. But we don't disappear. And so we remain as a resource to people after they leave. We can still answer questions, but it is a real challenge, as it would be for any of us if we change jobs, to make sure that we had continuity of care. And when a student leaves abruptly, there's actually a very good system at USC to make sure that that person does have, if they're willing, does have a bridging continuity of care to get them wherever they're going. So that's part of that. Our academic units, our risk units, and our health units are meeting every single week and reviewing those sorts of things. So if we learn from an academic or risk unit that there's a student who's going to be leaving abruptly, we'll double check to see if they're in care with us. If they're in care with us, we'll make sure there's a continuity plan. So thank you again for this opportunity. Thanks for this conference.